Very good morning to everyone. Today's topic is dentinal hypersensitivity. So it will be covered under definition, etiology, mechanism and theories of dentin sensitivity, method of measuring hypersensitivity, how we will be managing it, and then we will be summarizing it. So the definition is that it is a transient, short, sharp pain arising from exposed dentin in response to stimuli, typically thermal, evaporative, tactile, osmotic, or chemical, and which cannot be ascribed to any other dental defect or pathology. This was given by Dowell and Andy, and still this definition is considered to be the best definition, whereas many more definitions have come, but this is the best definition. Addy has also written a book on dentinal hypersensitivity. If you want to know more about it, you can refer that. And this is a very interesting statement that it is perhaps not surprising, therefore, that one can still have sympathy with statement made in 1987 by Johnson and co-worker that dentin hypersensitivity is an enigma being frequently encountered yet ill understood. If we talk about prevalence and distribution, 15 to 18% of the general population is some at one point of time have been affected by hypersensitivity. And 72 to 98% of the periodontal disease patients, they have complained of hypersensitivity. If we talk about the peak, it is 40 to 20 to 40, uh, ranging from 20 to 50 years. More females are affected than males. It can be due to females because they are more hygiene conscious. They might be brushing their teeth more vigorously, so there might be more of the enamel loss. Then either periodontal disease or periodontal treatment predispose to dentinal hypersensitivity, both having effects on dentin and gingival recession. Periodontal disease, yes, they do recede gingiva, and it is more prevalent on the buccal cervical aspect of tooth and where enamel is thin. So the most prominent surfaces of the tooth, they become exposed and respond to hypersensitivity. So most commonly teeth affected will be obviously canine, first premolar, then incisors, because we can brush here more vigorously, and then second premolar, and least often molar. They are very well placed. They are neither buccally proclined or lingually proclined. And yes, no plaque correlation. It's not that more of the plaque uh, which is there, so it will result into more of the hypersensitivity. It is not there. So there are two reasons why the hypersensitivity occur. So etiology is enamel loss and gingival recession. So if the enamel will be lost, dentin will be exposed. And how enamel will be lost? It will be lost by attrition, abrasion, erosion, and effraction. Gingival recession is one another method where the root get exposed, and from there the cementum, and then cementum, because cementum is very thin, dentin get exposed. So patient complains of hypersensitivity in both these cases. Enamel loss, how it will occur? It will occur in form of attrition. It is the mechanical method. Mechanical method means due to the patient, or physiological, better term physiological, when the patient is chewing, when masticating, it results into some sort of enamel loss. Mostly it is on the incisal or the occlusal surface. So this is the attrition. Then there is abfraction. Due to continuous masticatory forces at the cement to enamel junction, there will be loss of tooth structure resulting into abfraction. They are cavity-like structure, so that is the abfraction. And then there are two more terms, erosion and abrasion. Erosion is the chemical method. Chemical means if we are having more of the acidic food products, then it will result into erosion of the tooth surface due to the acid production. And sometimes the patient have the regurgitation, reflexes are there, bulimia patients, they result into erosion on the lingual aspect of the tooth. And then abrasion. Abrasion is the mechanical method. Mechanical method means if we are brushing the tooth vigorously, it results into some amount of bone loss, which is again more at the, it is saucer shape and more on the cementum surface, not on the enamel. Erosion occur more on the enamel and abrasion occur more on the cementum. So this is how the tooth loss takes place. Then other reasons can be improper instrumentation. If we have done more of the curettage on the root planing on the tooth surface, overzealous root planing on the root surface, we might take out some of the enamel from the surface or the cementum from the tooth. Not enamel, it is mostly the cementum which is more removed, resulting into hypersensitivity. So whenever we are instrumenting, we have to be a little bit cautious that we are not overzealous. And this is the cemento enamel junction. We have, you must have read about the cemento enamel junction. One is the overlapping, one is butt joint, and here it is where the cementum and enamel do not meet. When the cementum and enamel do not meet, it results into dentine exposure. So this is also one of the reason where there will be hypersensitivity. Now gingival recession, yes, again here the now the cementum is exposed, then the obviously cementum is because thin and soft, it gets lost and then dentine get exposed and patient feels the hypersensitivity. So what are the causes of gingival recession? It can be improper toothbrushing, the necrotizing diseases, self-inflicted injury, periodontal disease, periodontal surgical and non-surgical procedure, crowding and dehiscence. If we talk about how the lesion initiates hypersensitivity, how does it initiates? So it is first of all, what are the requirement? Dentinal tubule should be open, it should be patent. Sometimes it get obliterated, so it should be patent and it should be connected with a vital pulp. If the pulp is not vital, then whatever sensitivity is there, how much recession is there, the case where we do for the when we do root canal treatment, we reduce the tooth structure, make a crown over it. So all those things, the patient doesn't feel any sensitivity. But so the vital pulp should be vital for the hypersensitivity to be felt. Then we should know how, what are the various reasons due to which the enamel can be lost. So it can be the toothpaste containing more of the abrasive, they remove the smear layer through abrasive and detergent action. Erosive agent, particularly acid dietary food, readily exposes tubule. Soft drink, alcoholic beverages, yogurt, they remove dentine cementum layer. And erosion causes bulk loss of dentine and surface softening, which is very susceptible to physical insults. Agar if we take something hot, if we take something cold or anything, patient will feel the hypersensitivity. So what are the various mechanisms? How does this sensitivity occurs? So the various theories have been given, which are more common is the neural or nerve theory. This is not accepted, so I'm not going to explain. Odontoblastic transduction theory, again it is not accepted, so I'm not going to explain. Hydrodynamic theory, it is the most, hydrodynamic theory is by far the most widely accepted theory for dentinal hypersensitivity. It states that displacement of dentinal fluid within the dentinal tubule cause a deformation of pulpal mechanoreceptor, which in turn causes pain. Because there are no nerve, there is no odontoblastic cells which are innervated, so those two theories are not accepted. Hydrodynamic, there is some fluid in the dentinal fluid. If we say this is the nerve theory, which states that there is the nerve inside it, but it was found that there are no nerves inside it, so not accepted, not accepted. Then odontoblastic theory, again it was said that the odontoblastic cells, this process is there due to which direct stimulation of odontoblasts take place and causes. So again this is rejected, and the most accepted one is that there is a dentinal fluid inside the dentinal tubule. These are the dentinal tubule filled with dentinal fluid, and this fluid, when it's stimulate anything is comes over here, it stimulates and there is movement in the dentinal fluid. This movement in the dentinal fluid responds to the nerve ending at the pulp, and these innervations, they cause some degree of hypersensitivity or pain. So that's why it's always transient. This theory I'll be explaining more. This was proposed by Brainstorm in 1963, again in 1967, which states that rapid shift of the fluids within the dentinal tubules following stimulus application result in activation of sensory nerve in the inner dentine region of the tooth, that is pulpomechanical stimulation. Hydrodynamic theory is by far most widely accepted theory for dentinal hypersensitivity. It states that displacement of dentinal fluid within the dentinal tubule causes a deformation of pulpomechanoreceptor, which in turn causes pain. So again, this is the picture which is depicting that how these are the nerves at the end of the dentine where it meets the pulp. So the dentinal fluid which causes the hypersensitivity. Now there are two things difference between tooth sensitivity and hypersensitivity. So tooth sensitivity is it refers to increased sensitivity of a tooth that may be there are many reasons for that. It can be caries, it can be chipped teeth, it can be cracked tooth syndrome, fracture restoration, marginal leakage in restoration, post restoration sensitivity, etc. So they will not be called as hypersensitivity, they will be called as dentin sensitivity. And dentinal hypersensitivity is one type of sensitivity. So dentinal hypersensitivity can come under category of dentinal sensitivity, but dentin sensitivity, when we say, it is not related with hypersensitivity. Hypersensitivity will be a separate entity. सो हाउ क्लिनिकल असेसमेंट ऑफ डेंटिन हाइपरसेंसिटिविटी, हमें पता तो चले कि कैसे उसको देखना होता है। तो दो तरह हो सकते हैं, एक हम सब्जेक्टिव कर सकते हैं, पेशेंट विल टेल अस हाउ मच पेन दे आर फीलिंग, एंड अनदर इज द ऑब्जेक्टिव वन. So if we come into the subjective one, where the verbal rating scale is a simple descriptive pain scale which includes the following. If there is no discomfort, patient will tell, and no discomfort, we will grade it 0. Patient will say mild discomfort, will be grading it 1, marked discomfort 2, marked discomfort that lasted for more than 10 seconds, it will be marked at 3. So this is individual patient's own perception. They can, some patient might say mild discomfort to marked or marked to moderate depending on the pain threshold. Another is the visual analog scale. This is an imaginary scale. There is a line of 10 centimeter in length. The extremes of the line representing the limits of pain a patient might experience from an external stimulus. If it is 0 or 1 centimeter, it will be minimum pain, and if it is 10, that means it is the maximum pain. So we ask the patient to write between 1 to 10, and accordingly we perceive it. Then Meckel pain questionnaire. The patient is shown 20 sets of words and asked to select a word from each set which best describes the present pain experience. So these are the various subjective method by which we can measure the hypersensitivity. Now coming to more precise, that is the objective assessment. Mechanical or tactile stimuli. We use a sharp dental explorer and we run over it, and then we rate the patient's response. If the patient says that pain is there, so it will be graded between 0 to 3. So we are using a explorer to explore the pain. Then thermal sensitivity. Thermal sensitivity is directing a burst of warm temperature from the dentinal syringe onto the test tooth. And 1 second blast from air syringe, temperature is between 65 degree to 70 degree Fahrenheit and at a pressure of 60 psi. If there is no discomfort, 0, then mild, severe pain occur and persist even after removal of the stimulus. And these are all for the hot. And then we can also use ice stick. It can be ethyl chloride also, by which patient will tell about the pain. So we are using something to assess the pain. So they are more of the objective one. Also there is electrical stimulation. Electric pulp testers are there. It is battery operated, producing pulse of direct current. The intensity of the output voltage may be increased by presetting various numbered gradations on a thumb wheel. This is not very commonly used. It is more the thermal and the air flow on the to test the hypersensitivity. There is one more, stethoscope also. Again, this is not very common. It was developed by Stark and consisted of a digital readout sensitive voltmeter connected to a digital printer. The stimulus intensity measure in volts. So this is there, which is not very commonly used, just for your information. Then chemical or osmotic stimulation. hypertonic solution like sodium chloride, glucose, sucrose, calcium chloride. They are, it is irrigated on the tooth surface. The use of chemical solution is complicated because the solute in solution diffuses into the dentinal fluid. On repeated application, the osmotic pressure difference between the tubular fluid and the applied fluid would decrease and reduce the effect of the solution as our osmotic stimulus. To avoid this, long time interval must be followed between the application of the solution. So practically, again, it is least preferred. If we talk about the most preferred method, it is the tactile method, air blast, and the thermal method. So we most commonly we use these three methods to assess the hypersensitivity. Now coming to how are we going, we have assessed the patient suffering from hypersensitivity. Now how are we going to manage it? So management is always etiology based. So we have to think that why it has occurred at all. So we will think one first aspect is the prevention. Ensure proper toothbrush consistency. The brushes should not be too hard. Ensure proper brushing technique. It should not be scrub technique. Highly abrasive tooth powder or toothpaste should be avoided. Avoid overbrushing with excessive pressure or for an extended period of time, or excessive flossing. Sometimes excessive flossing also result into hypersensitivity. So we have to prevent excessive flossing. It should be once daily or on an alternate day flossing. Avoid brushing immediately after taking acidic drink, because when we take acidic product, there is some sort of erosion and gradually it remineralizes. But if we have immediately brushed, so we will some of the enamel will be released from there. Avoid over polishing. Again, in polishing we use so many abrasives, so avoid over polishing. Avoid over instrumentation. Avoid violating the biologic width during restoration placement. Patient with gastrointestinal reflex disease should be properly managed by the physician, and fabrication of occlusal splint to cover the affected areas to prevent their contact with the acid. So these are the preventive aspect. Now coming to हो गया सब कुछ. अभी now coming to how we can do the treatment. Now the treatment can be done. This is one classification given by Sherman and Jacobin in 1992. They have categorized into two categories. One is the chemical agent and another is the physical agent. In the chemical, basically our aim is to seal or block the dentinal tubule opening. Now these dentinal tubule opening can be sealed in various ways. So one is the chemical method. In the chemical method, strontium chloride 10% and strontium acetate 8%. They are used so that they form a with the hydroxyapatite of the enamel or the dentine which is there, it makes a calcium chloride over there and it blocks the dentinal tubule opening. So very commonly this strontium chloride and strontium acetate are being used in various form of paste. Here the patient can use it and can get rid of hypersensitivity. Then potassium nitrate, again it comes in the form of paste. Then the fluorides, sodium fluoride or stannous fluoride, and also few formaldehyde, not very common. Just for your information. So most commonly these three, strontium chloride, strontium acetate, potassium nitrate and fluorides are used. Then physical agents in which the dentist apply the specific agent. So it can be the restorative material like composites that we use for cavity filling. So they are the compomers. It can be the glass ionomer, a thin layer of glass ionomer, but these have to be applied at various interval because they get again upgraded if we have not taken the preventive measures. Then the varnishes, topical agent varnishes. Yes, varnishes, they do retain for a longer time period 30% of sodium fluoride, varnishes, potassium and ferric oxalate. So these are the various agents that can be used. One is by the patient, another is by the dentist. These are the various ways. There are many more. So one can choose from any. The Sensodyne, they are containing Novamin that I will be explaining. These are the advanced thing. One is that is containing the arginine, then strontium chloride and potassium nitrate, and these are the glass ionomer and all those things. There are one was the chemical, another was the physical, then is the iontophoresis of fluoride. This is again electrical method in which we block the dentinal tubule by the fluoride and the strontium ions. Laser is the latest, these are the current trend, like laser, neodymium yttrium aluminum garnet Nd:YAG laser, gallium aluminum arsenide laser, erbium laser, helium neon laser. So they have also been tried. They do some charring, and the dentinal tubule get blocked by that. So these are the current trends. And other can be if there is gingival recession, if the root is exposed. After performing all these things, we can go for a gingival graft procedure. We can cover the root by various graft procedures, soft tissue grafts. And sometimes when nothing is very effective, we also apply topical corticosteroid. Not common. Topical steroid application, again, that is not common. Then coming to the other current trends in treating the hypersensitivity, dentinal hypersensitivity. So they are the arginine based product, proarginine. Then it is the novamine. Then it is the casein phosphopeptide amorphous calcium phosphates. So various like sensodyne, that is repair and product, that is containing novamine, and again that is coagulating or blocking the dentinal tubule, and they are permanent. They remain permanently over there on inside the dentinal tubule and block the dentinal tubule. And nanodentistry is an emerging branch. With this, we can robotic dentistry can be there. So that keeps on occurring. So this is all about how we have done manage the hypersensitivity, diagnose and then manage. So if I talk about, if I conclude it, so professionals should first of all identify the positive factor, so that prevention can also be included in the treatment plan. That is one thing. So, and depending on the severity of dentinal hypersensitivity, clinical management may include both in office and self applied at home therapies, including recent and novel technologies that have been introduced. And the least invasive, most cost effective treatment is the use of an effective desensitizing toothpaste. Patient can purchase themselves from the medical store, or we can the dentist prescribes them, they can purchase, and they are the cheapest. If we have to apply some glass ionomer, composite, iontoporosis, we will be charging for that. So, in this, I conclude the topic. Thank you very much.